Hey friends, this is Natasha.
And Praniti, your fellow med students. As always, the purpose of these short podcasts is to give a quick overview of some topics we think are important for your clinical rotation and shelf exam. Today, we'll be going over a very high yield gyne topic, Flame Lecture 166, STI screening and prevention.
In this lecture, not only will we go over guidelines for STI screening, but we will also discuss the guidelines on notifying their partners. Most importantly, we'll be sharing the many STI prevention strategies that are in place. Additionally, we want to emphasize how social and environmental factors can impact the prevalence, incidence, diagnosis, and treatment of these STIs.
Before we get into the nitty-gritty of the screening guidelines, we want to say the CDC stratifies the guidelines by epidemiological categories, like adolescents versus pregnant individuals versus women who have sex with women, etc. This honestly helps showcase how different backgrounds can affect STI risk. There are 5 major strategies we can think about when trying to prevent and control for STIs.
The first strategy consists of accurate risk assessment, education, and counseling of people at risk. The second addresses pre exposure vaccination for STIs that could be prevented by vaccines. The third identifies symptoms associated with specific STIs. The fourth addresses effective diagnosis, treatment, counseling, and follow up. And finally, the fifth strategy goes into the actual evaluation and treatment of the sexual partners of individuals infected with an STI.
So it can be a little awkward taking sexual histories the first time, but it's honestly such an important skill to practice because not only can it allow you to learn about the patients and ascertain their risk factors, but also it's an important conversation that allows you to create a safe space for the patient to share vulnerable aspects of their life.
There are 5 main things you should focus on when taking the history. We call them the 5 Ps. So the first P stands for partners. So you'll want to ask the patient, are you currently having sex? How many partners have you had? And what are the genders of your partners? And all of these questions can help to better elucidate any risk factors they may have. The second P stands for practices. So what type of sexual contact do they have or have had? And you can be more specific by asking whether they have had vaginal, anal, or oral sex.
The third P is protection. Ask them if they're currently using any barrier contraceptives like condoms, or if they're getting tested, or if they've even started having the conversations with their partners about testing. The fourth P is the past history of STIs. Have they been tested in the past and have they been diagnosed / treated? You can also ask if they or their partners have had any history of IV drug use, which puts them at a higher risk for STIs. And then lastly is pregnancy intention. Do they think that they're going to have children in the future? And how important is it for them to prevent pregnancy until that time?
So now let's talk about the actual screening for STIs. When it comes to HIV, we want to test any individuals between 12 to 64 years old at least once. If they use IV drugs or have unsafe sex practices, it is recommended to be screened annually. It is also recommended to annually screen for gonorrhea and chlamydia in any sexually active woman under 25 years of age, or if they are older than 25 and are at high risk, such as if they have had any new or multiple sex partners.
HPV screening can be a little complicated, so please refer to slide 8 for the recommendations. But one major takeaway is that HPV screening starts at 21 years old and needs to be done every 3 years. The frequency of the screening may differ based on the results or based on the age.
So the prevalence of STIs are highest among adolescents. And one thing that you should make sure to emphasize is that they can consent to their own health services for STIs and that they do not need to inform their parents. This is true for all states.
Yes, please, please, please make sure to emphasize this because that'll make them a little bit more brave to talk about their sexual experiences. So for pregnant individuals, there are routine STI screenings that we do, mainly because the fetuses are at risk for very serious complications with various STIs. And these include HIV, chlamydia, gonorrhea, syphilis, and hepatitis B screenings. And they're all usually done in the first prenatal visit. So for a syphilis, though, we also want to do a retest at 28 weeks. And if they're high risk people with a history of like multiple sex partners or IV drug use, then we want to do a retest of HIV, chlamydia, and gonorrhea again at the third trimester.
So now moving into women who have sex with women. This population carries their own risk for STIs, especially if they have also had male partners in the past or currently. Because of this, screening should be nuanced by the type of sexual activity they are having, which is something you'll learn about when you take the sexual history, as we talked about before. While we want to take all of this into account, routine screening for all individuals in this population is recommended.
For transgender or gender diverse patients, based on how sexually active they are and the number of partners they have, consider routine screening for HIV. People with a cervix should undergo HPV screening. As mentioned before, take a look at slide 8 for those specific guidelines.
So for those in correctional facilities, approximately 50% of individuals are released back into the community within 48 hours. So there is a lot of mobility. However, those under the age of 35 who are in juvenile and adult detention facilities have been reported to have higher rates of chlamydia, gonorrhea, and syphilis than that of non-incarcerated persons. Because of this, it is recommended that they should undergo gonorrhea, chlamydia, trichomonas, syphilis, hepatitis, and HIV screening.
Okay, so now that we've extensively covered screening, let's talk about what to do when a positive test is seen for an STI. So one important part of management is counseling patients on partner notification so that there's decreased risk of reinfection for the patient and also an opportunity for partner evaluation and treatment.
So something called patient-delivered partner therapy allows physicians to actually prescribe treatments for gonorrhea, chlamydia, and syphilis, or trichomonas if the patient is pregnant, to the patients to give to their partners without the physician actually examining the partner themselves. So how do we actually help to prevent STIs?
One of the most important things to keep in mind as a physician is to provide non-judgmental and empathetic counseling that takes into account social determinants of health.
STI prevention can take many forms, such as male condoms, which come in a variety of materials, or female condoms. Additionally, topical gels like tenofovir, which is an antiretroviral treatment which has been shown to reduce HIV transmission by 39% in South African women, can be prescribed. There's also male circumcision, which is shown to reduce HIV and HPV transmission in Africa, as well as pre-exposure prophylaxis, or PrEP, to prevent HIV.
In terms of vaccines, there is the hepatitis B vaccine that is recommended for all people and ages, and then the HPV vaccine that is recommended mainly for youngsters between 9 to 26 years of age. But you can also offer to patients between 27 and 45 years old, and that's just really dependent on patient-physician shared decision making.
So that brings us to the end of this podcast. It's very important to counsel patients on the importance of STI prevention, screening, treatment, and partner notification. And as future physicians, we have to use inclusive and trauma-informed language to destigmatize the topic of STIs and provide our patients with a safe space to share their histories with us.
In your training as a med student and in your future career, you'll meet patients from different socioeconomic and environmental backgrounds. So it's in your best interest and your patient's best interest to understand how these environmental factors can affect healthcare and impact health equity. So be kind, be compassionate, and most importantly, be your patient's advocate.
Thanks for tuning in again.
Bye.
Bye.